Dr. Burton will be presenting virtually. Dr. Burton is a board-certified neuropsychologist with extensive experience in the assessment and treatment of patients with neurological and psychological disorders. Prior to joining Houston Methodist, Dr. Burton spent 5 years evaluating and treating patients with a variety of neurological presentations, particularly TBI and stroke, at the Institute for Rehabilitation and Research, or TIR. While at TIR, she co-directed the Neuropsychology Postdoctoral Fellowship. Dr. Burton has various research interests, although as a native Spanish speaker, she has a special interest in cross-cultural neuropsychology. She was the past president of the Houston Neuropsychological Society and current co-chair of the Tools and Norms Subcommittee of the American Academy of Clinical Neuropsychology's Relevance 2050 initiative.
Today I'll be talking about mental health and stroke. Some objectives for today include to learn about the association between mental health and stroke, gain insight about the potential impact of mental health on treatment compliance and stroke outcomes, recognize the importance of mental health and social support in stroke prevention, and appreciate the importance of screening for mental health conditions in patients with stroke and stroke risk factors. Here are some well-known stroke statistics. It's important to point out that while stroke is the leading cause of death for Americans, the risk of having a stroke varies by race and ethnicity. The risk of having a first stroke is nearly twice as high for African Americans as for Caucasians, and African Americans have the highest rate of disability and death due to stroke. Although stroke death rates have declined for decades among most races and ethnicities, Hispanics have seen an increase in death rates since 2013. Here you see a number of well-known modifiable stroke risk factors, which may be modified by mental health wellness and mental health care. This infographic nicely depicts a possible circular relationship between mental health conditions, physiological changes that increase the risk of stroke, and behavioral risk factors such as inactivity and medication noncompliance. According to the National Institute of Mental Health, over 43 million Americans aged 18 and above have had a form of mental illness within the past year. That's nearly 18% of all American adults. Regarding mental health as a stroke risk factor, anxiety, depression, PTSD, and other mental health disorders have all been associated with an increased risk of stroke. Adults with high levels of anxiety and depression have up to a 30% greater risk of heart attack and a 44% greater risk of stroke. Regarding post-stroke depression, approximately 30% of all stroke survivors experience depressive symptoms at some point following the event. This is highest during the first year following stroke. Risk factors for the development of post-stroke depression include increasing age, living alone, high levels of comorbidities, a history of depression, female gender, physical disability, stroke severity, cognitive impairment, and a prior history of stroke. Depression has also been associated with poor functional outcomes and higher mortality. Depression has been found to affect motivation in patients in rehabilitation. It reduces the rehabilitation effect, and it increases the family care load. In a meta-analysis of 17 prospective studies, Dong et al. In 2012 found a significant positive association between depression and subsequent risk of stroke. This is even after adjusting for potential confounding factors, including hypertension and diabetes. The associations were similar between men and women. Regarding post-stroke anxiety, the various anxiety disorders share the hallmark characteristics of excessive and irrational fear, subjective apprehension, and difficulty and distress in managing daily tasks. The prevalence of post-stroke anxiety ranges from 20 to 25%, and it remains a common problem several years after the stroke event. Post-stroke anxiety tends to be more common among those who are younger, female, unable to work after stroke, and of lower SES. A major contributing factor to anxiety in post-stroke patients is the fear of stroke recurrence. Therefore, educating our patients about their particular stroke type and risk of recurrence may help to reduce their health anxiety. Patients with stroke and comorbid anxiety and depression have been found to have higher levels of impairments in ADLs, greater cognitive impairment, and fewer social ties than those with depression alone. Some patients with stroke present with post-stroke fatigue. Various factors contribute to post-stroke fatigue, including physical impairment, limb disuse, sleep disorders, and depression. Wu and colleagues found that post-stroke fatigue is directly associated with depressive symptoms and directly or indirectly associated with anxiety, poor coping, loss of control, emotional disorders, and behavioral disorders. Stroke survivors have been found to experience more fatigue, both mental and physical, than the general population. Fatigue may prevent rehab participation and reestablishment of professional and social activities. Another condition that we see in stroke patients is post-stroke emotional lability, or pseudobulbar affect. This is an increase in the frequency of crying or laughing in response to non-emotive or incongruous stimuli. This can hinder recovery. About 20 to 25% of stroke patients are affected during the first 6 months after stroke, and 10 to 15% of affected patients remain symptomatic after 1 year. The rate of co-occurrence for depression and lability is 38%, and lability develops more often in patients with post-stroke depression than in those without depression. Lesion location for post-stroke emotional lability varies. This table nicely depicts the various characteristics of pseudobulbar affect and depression. When considering mental health and stroke care, outcome, and prevention, we must recognize the importance of social support. Social support is typically conceptualized as structural or functional. Structural social support pertains to the quantity of social contacts, whereas functional social support is more qualitative and involves those who are readily available to meet one's needs and serve a supportive purpose. It's important to consider in our patients who may live alone or who may be recent immigrants who have not yet established a support network. High levels of social support have been associated with faster and more extensive recovery of functional status after stroke. Social support has also been shown to positively predict post-stroke social and community participation. Social support by medical staff has also been studied. Saltera et al. In 2010 reviewed the effectiveness of social support interventions on post-stroke mood and concluded that successful interventions were initiated early, involved frequent staff-initiated contact, and incorporated continued screening for depression, and provided counseling where necessary. Karanen et al. In 2017 studied the relationship between the quality of lifestyle counseling and later adherence to lifestyle changes in patients with stroke and TIA. Healthier nutritional habits, improved physical activity, adherence to medication, and lower BMI were found at 1 year follow-up in their group with good perceived counseling interactions, education about the advantages of following the advice provided to them, and good counseling resources. Family support is another important factor in enhancing patients' ability to cope with stroke. High levels of family support have been associated with progressive improvement of functional status in severely impaired post-stroke patients. Belain et al. In 2017 found that better quality of moral support from friends and family immediately after stroke was associated with decreases in later depression levels and increases in activities of daily living. Functional support from friends and family was associated with increases in activities of daily living. Erler et al. In 2019 found that perceived social support by stroke patients at discharge from inpatient rehabilitation was a highly significant independent predictor of community participation 3 months later. Magwood et al. In 2020 reviewed the literature on community-based support for stroke patients and found improvements in patient perceptions of health, quality of life, knowledge, self-efficacy, self-management, and caregiver support. With regard to psychotherapy, cognitive behavioral therapy has been shown to be effective in treating post-stroke depression and anxiety. Kutker et al. In 2014 incorporated motivational interviewing, grief resolution, and psychoeducation to CBT in a rehab setting and found it to be effective for the treatment of post-stroke depression. The 2019 update of the Canadian Stroke Best Practice Recommendations for Mood, Cognition, and Fatigue Following Stroke recommends cognitive behavioral therapy as one of the first-line treatments for depression after stroke. Motivational interviewing is a person-centered communication method of fostering change by helping a person explore and resolve ambivalence. Rather than using external pressure, MI looks for ways to access internal motivation for change. Therefore, it includes a patient as a collaborator in his or her care. It uses 4 key communication skills known as OARs. This stands for asking open-ended questions, affirming, using reflective listening, and summarizing. Watkins et al. In 2017 found that motivational interviewing led to an improvement in patients' mood 3 months after stroke, as compared to a control group who did not routinely receive psychological services. Chen et al. In 2020 reported increased motivation for rehabilitation among stroke patients who received MI. Here's a nice summary of the OARS framework. Regarding SSRIs, studies of the effect of SSRIs on functional outcome in stroke have yielded mixed results. This is likely due in part to varying sample sizes and group compositions among studies, as well as the use of varying outcome measures. Gu and Wang in 2017 conducted a meta-analysis of 8 trials in 1,549 patients and concluded that early, or within 1 month of stroke, SSRI treatment improved neurologic function in patients undergoing rehabilitation after stroke. Zhu et al. In 2020 conducted a meta-analysis of 10 randomized clinical trials with a total of 5,370 patients and concluded that early, or within 1 month of stroke, SSRI treatment did not improve patients' post-stroke functional independence, but did reduce post-stroke depression. Given the information that we've reviewed thus far, it's worth sharing some brief mood screeners that are easy to use in various patient settings. Here we have the PHQ-9, which is a well-validated self-report measure of depression. This is a briefer version called the PHQ-2, which has just 2 items. There are also various depression screeners for patients with aphasia. The SADQ-21, the SADQ-10, and the SADQ-8 are 3 options. Here's the SADQ-10. For screening anxiety, the GAT-7 is an excellent option. This is a well-validated self-report measure of anxiety that was modeled after the PHQ-9 to be used quickly and effectively within a primary care setting. For screening of emotional lability or pseudobulbar affect, we have the CNS-LS. To conclude, here are some recommendations based on the literature reviewed. Incorporate mental health screeners in hospital and clinic settings. Spend time discussing the importance of controlling modifiable stroke risk factors, including mood disorders, as they pertain to stroke recovery and future stroke risk. Use motivational interviewing techniques and include the patient in treatment planning as much as possible. This is to increase their commitment to change. help the patient identify their social support network, and include a loved one in goal setting and treatment planning. Provide post-discharge follow-ups to check on mood and treatment compliance. Direct to support groups and community resources. This is especially important for our more isolated patients. Refer to neuropsychology or other mental health specialists, and consider pharmacotherapy.